So I'm one of the fourth year surgery residents, which I hope means no longer described as barely able to tie my shoes. I was asked to speak on current and future use of robotics in urgent and emergent general surgery. I have no disclosures, maybe one day. The objectives I was given, the current state of robotic use in urgent and emergent general surgery, identify the benefits of robotics in these cases, and identify future opportunities for urgent and emergent robotic surgery. So as I started to dive into this, the earliest stuff I started to come across came out of the colorectal surgery literature, which started usually in about 2012 is when the Emergent reports started to come out. In 2012, there was a case report out of Texas Medical Center in Houston. An elderly woman had presented with an acute perforated sigmoid colon from colonoscopy. And they were elected to repair that via primary calorrhaphy robotically. She did great, discharged on post-op day 4. I thought this was interesting. I've seen the same presentation in other places that ended up being full exploratory laparotomies, as well as occasionally repaired via laparoscopy. A little bit later, 2014, a case report came out. An 86-year-old presented with a massive lower GI bleed, had a CT scan showing a large mass in the right colon, and got a colonoscopy first, and was able to somewhat control the bleeding. Patient was stable, so went for a emergent robotic assisted right hemicolectomy. Again, patient discharged post-op day 6 without any major complications in their hospital course. In 2019, a case control study came out from colorectal surgery regarding the use of robotics, specifically in the ulcerative colitis patient requiring urgent subtotal colectomies. The total population in the study was only 19 patients. In comparison, it was 6 robotic cases versus 13 laparoscopic cases. The robotic subtotal colectomies on average took about 29 minutes longer. There was no significant difference in blood loss. There was no significant difference in the complications, but there was more complications in the laparoscopy group versus the robotic group. 2 of the laparoscopic patients required reoperation versus 0 of the robotic patients. And then the robotic group on average had earlier stoma function and a shorter length of stay, but again, not statistically significant. It is worth noting that this was a single center study, and it was based off of 2 colorectal surgeons that did both the robotic as well as the laparoscopic cases. So the patient population that they elected to take for robotic surgery tended to be ones that they felt like they were less likely to be able to complete laparoscopically, which kind of, I feel like, changes the way these numbers are viewed. The fact that, the robotic took 29 minutes longer, but in a much more complicated case. So we don't really know how long it would have taken if they had chosen to stay laparoscopically or do it open. Following the colorectal surgeons, I started to see data about hiatal hernias. 2020, a case series of 3 patients who underwent emergent robotic assisted hiatal hernia repair for incarcerated hiatal hernias with gastric volvulus. There was no significant difference in comparison to laparoscopic repair from nationally published data, and the conclusion that these authors drew, was that there may be advantages to approaching it robotically depending on surgeon comfort on the robotic versus laparoscopic platform, as well as on the surgical team's experience level. In 2019, found data coming out about cholecystectomies done robotically. This was a case series of 3 patients who underwent urgent robotic assisted laparoscopic cholecystectomy. They found no difference in outcomes in comparison to laparoscopic surgeries at their institution. I did find further literature, however, larger studies have come out in comparison when they retrospectively go back and identify that the gallbladder had that it was either a gangrenous cholecystitis or showed evidence of necrosis. And in those cases, there was statistically significant difference in complications, in length of stay, and in conversion to open surgery in favor of robotic surgery over laparoscopic surgery. Um, Abdominal wall surgery also involved 2021, a retrospective study out of Tufts University of Medicine. This was a 34 patient study on emergent robotic ventral or incisional hernia repair. They didn't necessarily compare this to any national data or to their institution, but reported 20% minor complications, 11% major complications, and only 1 out of the 34 patients recurred within mean follow-up time of 20.5 months. So the conclusion that they drew is that robotic surgery can be effective in emergency settings in the cases of ventral and incisional hernia repair. Again, depending on surgeon comfort on the robotic and laparoscopic platforms. Um, so where are we going? What are the future uses of robotics in emergency and general surgery? The adoption of the robotic platform during night and weekends will be important for this in order for staff to be comfortable with the technology. That's something that we've kind of started to incorporate here at our institution. The limitations, increased time of surgery, the time required for robotic setting and docking, and accessibility of the robotic platform for emergency surgery. Um, However, when the entire team is trained, that can drastically reduce this time to start um, and have a significant impact on the overall duration of the surgery and kind of help limit that limitation. Literature suggests main potential advantages of the robot over laparoscopy are mostly in suturing and dissection. Um, Other things that I've come across in favor of the robot: increased dexterity. The magnified three-dimensional camera can have a big impact on cases. Having a stable camera sometimes save the surgeon's voice from yelling at the intern to hold the camera upright. Um, no tremor, and then the endo-wristed instruments and simultaneous use of energy devices can all have impact. Um, the barriers, access to the robot, especially during emergency surgery. A lot of times, if there's not a spare robot designated for emergency surgery groups, the robots are often scheduled for the majority of the day and across multiple specialties. They require more staff to be trained in order to cover nights and weekends. I can't always know when the emergencies are going to come in, and then having 24/7 availability of instruments. And then the other barrier to cross is the increased cost of the robot over laparoscopy, which we'll talk a little bit more in a minute. I've come across a few cases recently. I was at the SESE conference in Tampa a few weeks ago, and most of these were presented there that I felt like highlighted these differences. When I was a PGY2 on a transplant rotation, we had taken a patient back to the OR after a liver transplant for bleeding and evacuated a hematoma, but didn't identify an obvious bleed. And as I was presenting the patient, the critical care medicine doctor, in kind of a snarky tone, said they never find the source of the bleed. A few months later, I was doing a thoracic rotation at a different institution. We did a right lower lobe lung lobectomy, and the patient continued to bleed postoperatively in the chest tube. So the surgeon decided to call in the robot team at 10 p.m. at night, which they were not thrilled about. But he was actually able to identify a branch of the lobar artery that was bleeding and ligate it. And in my conversation with him, he specifically said he did not feel like he would have been able to see that bleed had he done it laparoscopically. Um, Somewhere where I was surprised to find The robot being used was in trauma. This was a case that was presented as a 28-year-old female, 2 gunshot wounds to the right upper quadrant, thoracoabdomen. Initially presented in extremis, but responded to transfusion, went to the ICU. There was concern for a diaphragm injury, so the surgeon decided that he was more comfortable repairing that robotically, especially in the right upper quadrant. Other advantages they found were in the case, he was actually able, through the diaphragm injury, he could evacuate the hematoma in the thorax, decorticate the lung, and strip the fibrothorax. And then they repaired the diaphragm injury and got out. Another case I came across was robotic repair of a gunshot injury to the trachea. This is a 2023 case report. The patient was transferred to a trauma center with a thoracic gunshot wound. There's evidence of a mid-tracheal injury with minimal parenchymal injury. So the patient was put on ECMO support, but they were able to go in robotically and repair the trachea successfully, and the patient actually went home on post-op day 3. Another one I came across at the SCSE meeting, 72-year-old male presented to the ER with right upper quadrant pain, radiating to the right shoulder, had a notable history of cirrhosis, and AFib, was taking Eliquis. CT showed moderate hemoperitoneum with a blush. So IR angioembolization was attempted but failed. Patient ended up going into hemorrhagic shock. They started with laparoscopic suction to evacuate the hemoperitoneum and identified a section 7 bleed from the liver, an arterial bleed that they felt like would be difficult to do to fix laparoscopically. So they docked the robot at that time. The increased mobility allowed for easy suture placement to ligate the arterial bleed. And then the patient got microwave ablation in the same case to treat hepatocellular carcinoma. So I came across a report in the World Journal of Emergency Surgery. This is from the World Society of Emergency Surgery. They came up with 6 position statements that, after a thorough review of research regarding the use of the robot in emergency surgery. Their first statement says robotic surgery in emergency setting is highly dependent on the surgeon's experience and should only be performed in an appropriately equipped operating room with trained nursing staff. So this kind of falls on the institution to have trained staff as well as surgeons who are more comfortable with the robotic platform than laparoscopic or open. The second statement is robotic surgery in emergency settings may be considered in highly selected, clinically stable patients only. And they go on to cite several papers about the increased time it takes with the docking of the robot. So they recommend clinically stable patients, so you're not prolonging that. Third statement is robotic surgery may be considered in challenging situations which are foreseen as a reason for conversion to open surgery if operated in laparoscopy. This is what we've kind of talked about extensively, the benefit of the robot in preventing open surgery as well as other complications when it's done laparoscopically. Number 4, in the near future, robotic surgery may offer the advantage of telemonitoring and telesurgery, which could be useful to promote a safe and standardized application of robotics, also in low volume centers or specific environments. So that's kind of a possibility of where this could go, specifically in emergency surgery. Number 5 essentially states that if in order to conduct emergency surgery, the institution has to find ways to do it without affecting the flow of the rest of the OR. And then 6, also development of new robot platforms may facilitate this. So barriers, I came across a 2023 retrospective study. They went through the 4 most common emergency robotic procedures and compared them to laparoscopy in terms of costs and complications. The first procedure was cholecystectomy. The main things here on all of these will be the total cost, which is here. The total cost was statistically significant in all four, increased in robotic surgery. The next one was appendectomy. Again, the cost was increased. Inguinal hernia, again, demonstrates increased cost when done robotically over laparoscopically. And then ventral hernia, again, shows increased cost. I think it's important to point out that this is, again, institutions where surgeons had the option of proceeding with laparoscopy or robotic surgery. So it was not a randomized trial. The patient populations were very different, and the patients that were treated robotically were at increased risk of open surgery or other complications. So the total cost really shouldn't be the only deciding factor in these cases. But their conclusion was that robotic emergency general surgery was associated with higher hospital costs, with similar benefits or similar outcomes to the patients, but that appropriate patient selection could offset that cost. And that was, again, going back to the fact that they had similar outcomes despite much more complex procedures on the robot.
Excellent presentation. For the record, the two shoe tying comment was aimed at one specific resident. I'm just curious, after everything that you've researched for this talk, is there any procedures in particular that you don't think we should be doing in the emergent setting robotically?
I think that damage control surgery would probably be the number one.
Okay.
Severe trauma, unstable patients, where it's all about just stopping the bleed or something and getting patient to ICU for resuscitation. It was probably the only one that I would say shouldn't not be done under any circumstance with the robot.
Right. Thank you.
Thank you.
Anyone else? So I had a question on just thinking about the cost stuff. What are your thoughts on kind of what those procedures were? If so specifically, I mean, I have the most experience with hernias. If you're looking at like inguinal hernias or ventral hernias, why do you think the robotic ones were more expensive than the laparoscopic ones?
Why were they?
Mhm.
Likely operating room time, and then the instrument costs. I won't claim to be an expert at all on hospital finances, but again, there's no randomization to those. There's no saying that had those robotic cases been done laparoscopically, there could have been more complications. Those patients could have ended up in the hospital for extensive periods of time, as well as they could have had to proceed to open surgery. All those things that until we have actual randomized controlled trials, we won't really know.
You likely hit it.
That was a trick question.
No.
He knows the answer, and you did a great job. You got the right one. So
You did pick the right answer. No, you're exactly right. In that most of the papers that have been written so far, when they talk about cost, look at operative time and pretty much operative time alone, because it's extremely hard to do exactly what you're saying, which is to know, for even hospitals, to know how much a case costs. We're struggling to do a project like that right now here. So you're right. Most of the papers that you see, if it's talking about cost, it's really just a factor of operative time. So good job.
Yeah. The other thing is they don't really indicate at all how well trained staff is to cover emergency surgeries. So that's not reported in any of these papers. It's very possible that they have kind of untrained staff covering nights or weekends on the robot, that would drastically increase the operative time.